characterized in 19th century, a total information taken because it is characterized generalized cause. It is intestinal infection disease, but characterized generalized form. Intestinal infection disease of localized form will be discussed Friday. Tuberculosis and cholera, shigellosis, but typhoid fever, intestinal infection is why? Because fecal oral mechanism of a disease, but don't develop in localized form. First time developing generalization process, specific characteristics. It's information about this disease registered in antique, yes, and last century detected what is infection agent, detected remedies and laboratory diagnosis. But why you discuss this theme? Because our century of resistance and characterize a typical cause of this disease and characterize resistance against antibiotic therapy. Another clinical picture, and actual in the endemic regions. How many students now present? 3? 28. Okay, doctors, please look. What's mean typhoid fever definition? Is an acute anthracnose infectious disease. Is anthracnose, you understand, who is source of infection? Human with fecal oral transmission mechanism characterized by a cyclic cause. What means cyclic? When after one period followed next period. Characterized periodically. And intoxication, bacteremia, and ulcerative lesions of the lymphatic apparatus of the small intestine. And you understand, infection agent of typhoid fever, lymphotropic, affected lymphatic tissue of the small intestine. The small intestine is this region of the gastrointestinal tract where rich lymphatic tissue. Please copy definition.
Professor, your microphone is turned off. Your microphone, we can hear you.
Sorry. Oh. And doctors, thank you, Isabella. And what's mean typhus? It is loss of consciousness, and will be discussed rickettsiosis, typhus, when characterized developing encephalopathy. It is common syndrome, encephalopathy. And when developing typhoid fever, you understand developing marked intoxication syndrome and developing toxical encephalopathy of brain. But infection agent of typhoid fever, Salmonella typhi, was first discovered in 1880, and German histology above detected in the section materia in the spleen, in the lymph nodes, mesenterical lymph nodes, and pear patches from people who died of typhoid fever. And you know what is infection agent? It is bacteria, Salmonella typhi. Doctors, it is gram-negative bacteria. I said you will be discussed salmonellosis. From this family Salmonella, detected Salmonella enteritidis, typhimurium. It is infection agent of salmonellosis, but Salmonella typhi is its infection agent, typhoid fever. From one family infection agent, but another. For example, you have family, but you and your brothers and other humans, and it is from this family Salmonella. And in 1896 Dr. Gruber discovered the phenomenon of agglutination of typhoid bacteria, what is Salmonella typhi, using specific serum. And a little later, Vidal, Vidal, it is a book of where total information about all remedies. Scientist Vidal applied this discovery to the development of reaction agglutination for diagnostic purpose, Vidal reaction. And this time we administer reaction agglutination, reaction, Vidal reaction to confirm diagnosis. A detailed description of clinical picture of typhoid fever was subsequently made in Pyatnitsky, Britannia, Botkin, and Russian scientists. It is Ivantev, Rosenberg, Padalka, Bilibin, Bunin. And when you discuss a clinical picture and signs of typhoid fever, have names of these scientists. Sign of Rosenberg sign, Padalka sign, and full information about disease you know. But this disease, actual present vaccines against this disease, you have remedies, antibiotic therapy, you have a reaction to confirm diagnosis. But I repeat for you as online students, because my microphone don't work, what is developing resistance and result resistance change characteristic of Salmonella and change first time clinical picture, another now different clinical picture than many centuries ago. But you will be discussed classical, typical clinical picture, and after you will be discussed specific characteristic of this time. And doctors, I said to you, it is endemic disease. What is necessary condition? High temperature and water. What is regions, please? And registered, usually it is typhoid belt, where registered as Salmonella typhi. First time it is Indian continent, subcontinent, and Africa, strongly endemic regions, Mexico and Africa and India. And endemic regions and other countries in Southeast Asia and countries from Latin America. And sporadic cases registered in the Russian Federation, East and West Europe, and North America. Right. And what is incidence? When 25 humans registered cases of typhoid fever registered to 100,000 patients. And it is incidence of typhoid fever higher. And it is actuality. This time, this disease actual. And etiology. I said you, infection agent, Salmonella typhi, gram-negative bacteria, Enterobacteria cereus, family, genus Salmonella, species, Lepidoptera, Salmonella enterica. It is gram-negative bacteria, and you know, if bacteria gram-negative, this bacteria has endotoxin. If present endotoxin, developing intoxication syndrome. And well stained with aniline dyes, mobile due to flagella, and capable to reversion to L form, and characteristic L form transformation. If bacteria may L transformated, this time phagocytes don't may affected this bacteria function of L transformation. And you know from definition, Salmonella typhi, like lymphatic tissue affected lymphatic tissue. It is lymphotropic, facultative, and intracellular parasite. Persists and reproduce in macrophages. And antigen composition of Salmonella typhi is composed of thermostable somatic or antigen or polysaccharide part of endotoxin. More superficial somatic V antigen, superficial, and thermolabile filamentary H antigen. And why necessary now what is antigen? Laboratory diagnostic connected with these antigens. Basic characteristic, gram-negative, lymphotropic. Copy? Okay, continue? Okay. Goes? Okay. And it is facultative anaerobe. And optimal temperature for reproduction of bacteria is 37. And doctors, you understand why this disease registered in tropical and subtropical countries? Because in the countries of North Europe, where temperature cool with absent optimal temperature, and it grows well on usual nutritious mediums and better on bile-containing ones. And doctors, if good medium bile, you understand, developing bile carriers, and in the bile ducts present in the bile of human, when developing carrier, this in the bile sitting bacteria present. What is
this temperature for the development bacteria out the host or in the host?
In the host, it is in the host it's human, but don't only host, environment. When temperature decrease, absent of optimal temperature to reproduce. No, doctor. Body human normal 36.6, yes, and bacteria infected human and living. It's but when temperature low, I said it's environment temperature. You now discuss specific characteristic bacteria. You don't discuss the clinical picture. It's etiology of bacteria. And I said, why the registered typhoid bug? Countries where temperature subtropical and tropical higher. Temperature 37. And you understand, in the winter, disease is not actual because minus temperature affected bacteria is don't reproduce. And it's persistent to external medium. It can survive in water to 3 months, in ice to 2 months, but only present but don't reproduce, and in soil during winter on fruits and vegetables during 5 to 10 days. Able to reproduce in meat and dairy products. Salmonella typhi instantly perishes boiling heat. And you understand, what is prevention measures? If you drink in boiling water, you don't may infected typhoid fever. If you drank water from ponds without boiling, you infected. You are infected. And simple disinfectants, 3% solution of chloramine, the ratio of 1 to 1,000 solution of Soluma, 5% solution phenol, 3% solution Lysol, kill Salmonella typhi, and during short time, only 2-3 minutes, and Salmonella typhi disinfected. It is disinfectant, simple disinfectant you must administer to clean, flat, where detected patient with typhoid fever. Have any questions? Okay, are you copied? Continue. And doctors, epidemiology. I said you, from definition you know, it is entrepreneur's infection. Who is source of infection? Human and ill human and carrier. Why carrier? Because in a human's body present bile, yes? Bile bladder, bile duct, and bile good medium to live and reproduction. Salmonella typhi. Sources of infection are ill patient, convalescent patient, bacterium carrier, which is Salmonella typhi with feces and urine. Doctors, my question, who is epidemiological hazard from all groups? Ill person, convalescent, and carrier. Who is epidemiological hazard? Very good, carrier, because carrier without clinical picture, don't hospitalize, don't isolate it, and had contact with humans. And from all people, usually who work in food industry, carrier, who work in food industry, because have direct contact with products. And maximum excretion of a pathogen into the environment with feces from the 80th day of illness. Doctors, why will be discussed when discuss pathogenesis, you understand? And the incubation period and first days of a disease in the ill person absent Salmonella typhi in the feces. Only on the second week of the disease, high concentration Salmonella typhi in the feces. And doctor, it is you will be discussed salmonellosis and shigellosis, and you understand. Bacteria must be kept in human population and transformated and developing 3-5% bacteria carrier. It is reservoir of the infection agent. And 3-5% of reconvalescents developing bacteria carriers, decreased population groups, food workers pose an epidemic danger. And doctors, this bacteria must be kept to evolution and infected new humans. It developed carrier. It is magic figure, 5%. 5% after salmonellosis, localized salmonellosis, developing carrier. After shigellosis, developing 5% carrier. And after typhoid fever, 5% convalescence is bacteria carrier, a bacteria carrier. And doctors, first bacteria carrier registered detected in the United States. Please look, it is typhoid Mary. Maybe you are listened about Mary Mellon. It's Mary Mellon, last century, 1899. Yeah, worked in the rich families. Mary was cooked and infected 53 persons, and 3 persons died. Outcome was lethal case. Why? But Mary clinical picture absent. Mary condition was good, healthy, and 2 times Mary isolated, and second time Mary isolated during lifelong. But Mary negative information, don't want isolated, and said, I don't infect it, I don't cause of infection. But then information about Mary during life, Mary don't infect the typhoid fever. But scientists think maybe Mary infected during mother's pregnancy, from vertical infected. Why? Because on the pregnancy period, Mary's mother infected typhoid fever, and Mary was born with Salmonella typhi. And this information, and please look, it is a photo of when Mellon hospitalized to quarantine, isolated. But why first time attended to Mary? Because in the rich families, registered typhoid fever, usually disease is not characterized to rich humans. Usually it is disease characterized to poor persons, poor sanitary measures, and question why these humans from these rich families infected. And when talking with members of the family, you understand not infected only members of the family, and service humans infected typhoid fever. And after examinated and Mary Mellon, and so because in each family where registered typhoid fever was worked Mary Mellon. And doctors, it is a history of Mary Mellon characterized first carriers of typhoid fever. And you know what is a specific characteristic of United States? Democratic. But isolation human, it is disturbed democratic, and usually people from United States say it disturbs democratic, and Mary was from Ireland, and it is another situation to migrants, and this limited of migrants. And it is history of first carrier, registered carrier. And doctors, mechanism, fecal, oral of disease, and transmission ways. First time of focus epidemics connected with water. Waterway epidemics with high incidence and duration over time. Usually when canalization water go to the central water, bad canalization system. Usually it is a situation characterized to developing countries, economical poor countries. And contact household route. activating during water epidemics and contact households, usually when poor sanitary measures in these members in these families, contact with household. And food route, it is explosive morbidity, and food route, who is source of infection usually? Carrier, who work in the food industry. For example, in the food city, no, it's all cooking in the restaurant, in the dinner, coffee, and source of infection. And demonstrated why this disease was actual in all countries last century, in Europe, in Russia Federation, typhoid fever last century was actually why? Because last century absent central canalization and absent central water. Please look. Patient go to the WC in the village, yes, and in the ground go feces with bacteria, and from this ground water go to the well water, and you take water, you drink, and infect it. Together, please look. Russian woman was contaminated, for example, cloths, and infected. And this water go to a grove, and from groundwater go to a well. And please look, children play and contaminated water, and water go to the ground. And its disease was actual in each continent and each countries in the what would this period? Summer period, when temperature higher. But now, when central water and canalization central, this disease registered only in the villages in endemic countries. And for example, in India, when you go to Delhi, you don't infect, but you go to the village, you may infect the poor canalization system. It's full information about epidemiology. And susceptibility of non-immune population is common. Post-infection immunity is stable during life, but the cases of repeated typhoid fever are now and present. Why? Who is infected second time? Who has poor immune response for immunodeficiency humans. And seasonal distribution of morbidity is characterized by rises in the summer-autumn period. The latter is especially typical for endemic areas against the background of a shortage and unsatisfactory quality of drinking water. And doctors, who is epidemiological hazard? Chronic bacteria carrier. It is source of infection. Chronic. And the presence of chronic bacteria carriers and the lack of effective methods of their sanitation determine the possibility of sporadic and epidemic spread of typhoid fever practically in any territory at any time of the year. And doctors, after disease developing lifelong post-infection immunity, but maybe registered rare cases, repeated cases of disease, and characterized season. In our country, it is a summer-autumn period, and epidemiological hazard, who is chronic carriers, source of infection. Copied? Okay. I have a question about etiology and epidemiology. No. And Next part of our discuss, it is pathogenesis. Doctors, you know, Salmonella typhi lymphotropic. Patient drank water contaminated and egg contaminated. Prevalent what is food? Fruits and vegetables, yes? And from products, what is who work in the food industry and contaminated products. It's maybe what is products where rich protein. It's milk, for example, meat, and patient. But from the nature, it is fruits and vegetables because grow yes with fruits and vegetables, and presented to lymphatic tissue. Please tell me where lymphatic tissue on the way of the Salmonella typhi first time. Yeah, that's good. A lymphophoriginal ring and one part of the Salmonella typhi presented to on lymphatic tissue of the oral cavity, and prevalent part of the Salmonella typhi pass to the stomach, and stomach, what is medium? Acid medium. Acid medium affected Salmonella typhi. And doctors, I said you, it is disease actual in the Indian continent. And in the India, don't register only typhoid fever, register cholera too, and another disinfection diseases. And culture of humans from India, usually before add food, usually humans drank water with lemon. What do you do, lemon? Increase acid barrier. It's a historical recommendation, culture of, and usually it's increased testing, food, and together it is a prevention measure. And I know, and this first time in India, but in good person, like this culture, drink water with lemon, take from India, this culture. And doctors, maybe who have good function of the stomach with typhoid Salmonella typhi inactivated and stop clinical picture. Why? One member of the family infected, but next second member is not infected because this human has good acid barrier. But Salmonella typhi from water, what do you do water? Water decrease pH of acid barrier. And maybe this Salmonella typhi was in the center of the food and don't inactivate it. And go to the pass to the small intestine. And distal part of small intestine, it is region where rich lymphatic tissue with its solitary follicles, pair patches, where Salmonella typhi presented and replicated in the lymphatic tissue. And doctors, it is way Salmonella typhi from oral cavity to and replicated to lymphatic tissue. It is incubation period, and after stop incubation period, Salmonella typhi from lymphatic barrier go to the bloodstream. This time developing primary bacteremia and developing clinical picture, bacteria in the bloodstream. And doctors, please look in the scheme of the disease and Salmonella typhi in the lymphatic apparatus of the small intestine. And is in macrophages, in the paired patches, follicles, mesenteric lymphatic nodes, and replicated, and after go to the blood and developing primary bacteremia. And answer to bacteremia, T cells developing phagocytosis. Result on full phagocytosis, incomplete phagocytosis, developing endotoxemia. Phagocytes affected Salmonella typhi, developing disturbs wall of Salmonella typhi, in wall of Salmonella present, in the wall present endotoxin, and together developing bacteremia and Endotoxinemia. If developing endotoxinemia, what is appear? Endotoxin. Intoxication is very good, very good. Developing intoxication syndrome. Doctors, first manifestation of typhoid fever, it is fever, increased fever, and developing signs of intoxication syndrome. And Salmonella typhi from blood go to the parenchymatous organs, where breast, reticular endothelial system. What is organs? It is liver, it is spleen, it is bone marrow, and kidney, and replicated in this reticular endothelial system, disseminated in organs of reticular endothelial system. And from this, from bile, Salmonella typhi, replicated in the liver, and from bile ducts, go to the small intestine. And this time, when Salmonella typhi from bile pass to the small intestine, where you detected Salmonella typhi? In the feces. Doctors, and with urine, Salmonella typhi from kidney pass to the urine bladder, and after developing urination and Salmonella typhi leave human body. But this time, developing elimination, human sanated, but in this feces and in the urine, you detected Salmonella typhi. So it is second week of a disease. First week of a disease, where you detected Salmonella typhi? In the blood, clinical. When in the intestine, absent clinical picture, it is incubation period. But when developing through blood, developing primary bacteremia, and you administer blood culture, and you detected Salmonella typhi, first days of a disease. And second week of a disease, you detected Salmonella typhi in the feces and in the urine. And together, Salmonella typhi repeat from small intestine, when replicated in the lymphatic tissue, go to the bloodstream, developing secondary bacteremia. And doctors, this time when developing secondary bacteremia on the second week of the disease, when Salmonella typhi leave human body, but secondary bacteremia increase level and the toxin in the bloodstream. And first we characterized intoxication syndrome, but on the second week, intoxication syndrome increased than first week. Why? Because concentration and the toxin increased. Do you understand me? And doctors, when Salmonella typhi repeat with bile go to the small intestine on the first week of a disease, what is developing in the lymphatic tissue? Salmonella typhi replicated in the lymphatic tissue and go to lymphatic tissue. What is developing? When infection agents come to cells. Inflammation, sensibilization and inflammation. What do? Inflammation. Pressure to wall of intestine. Result developing pressure. What is developing? This stops vascularization. If stop vascularization, what is appear in this part? Necrosis. And when after necrosis, what is developing? Ulcer. Under necrosis, developing ulcer. And doctors, you understand, on the third week of a disease, what you waiting? Ulcer process, rejection necrotic mass, and developing ulcer. You understand me? And third week of a disease, intoxication syndrome, and second week of a disease, when Salmonella doctors, first recovery disease developing intoxication syndrome, and after when salmonella typhi go to the organs of reticuloendothelial system, what do you do with organs? Mesenchymal inflammation, what do you do with the organs? Increase size and affected with organs and affected bone marrow, spleen, lymph nodes, and kidney and liver. And you understand, liver and spleen increase, yes, together after from liver and from kidney, salmonella typhi leave human body with urine and with feces. And when go to repeat to small intestine with salmonella typhi, sensibilized lymphatic tissue, developing inflammation. Result developing inflammation stops vascularization of wall of intestine, and on the third week, end of first days of the third week, developing necrosis, and after developing rejection and developing ulcer process. And doctors, but salmonella typhi, when go repeat to the bloodstream, developing secondary bacteremia, and this time, second week of the disease, increase intoxication syndrome because concentration in the toxin increase, and repeat from vessels, salmonella typhi go to the internal organs of reticuloendothelial system, developing dissemination. But on last century, when absent without antibiotics, who have good immune response, who is healthy, who is strong, salmonella typhi disappeared, sanated, and developing recovery. But you understand what is complication you're waiting. When increase on the second week of a disease intoxication syndrome, intoxication, what is complication are you waiting? First week intoxication was, but second week concentration toxin increased 2 times. What do you waiting? What is complication when developing intoxication syndrome? Infection, toxic shock, and toxic infection psychosis, developing affected central nervous systems, encephalopathy. And together, doctors, you understand increased liver and spleen sizes, but when developing rejection of ulcers, what is appear? Rejection, necrosis, and developing ulcers, what do you wait complications? What is? Perforation and bleeding. And doctors, from pathogenesis, you understand what is complication will be. Do you understand me? Okay, and please look, doctors. Morphological changes of the intestine. First week of disease, initial period, cerebral swelling of paired patches and solitary follicles. Why? Developing sensibilization. Result, sensibilization with inflammation, pressure to vessels, developing necrosis, and end of second week or third week of the disease, rejection of necrotic mass, and result, rejection necrotic mass, developing dirty ulcer. What means dirty? The ulcer has a necrotic mass. On the fourth week, necrotic mass disappear at stage of clean ulcers. Doctors, dirty ulcers, clean ulcer, when developing, time when developing, complication, bleeding and perforation. It is surgical complications. And 5 and 6 weeks, it is convalescent period when ulcer healing.
I explained just for first point in the first 3 quarters of the superior part, but
patches and solitary follicles. It is formation of lymphatic tissue in the small distal part of small intestine and bare patches. Do you understand? Online students, I have questions.
Can you repeat how the? Oh, sorry.
What is question? Please, Isabella, repeat.
Repeat what you said, please, about the lymphatic tissue and Peyer's patches.
Lymphatic tissue. It is what is lymphatic tissue of the distal part of small intestine? It is bare patches and solitary follicles and Salmonella typhi lymphotropic infection agent and replicated in the lymphatic tissue of the small intestine. But it's not only enterocytes in the lymphatic tissue.
Okay, thank you.
Why developing cerebral swelling? Because Salmonella typhi in the incubation period replicated in the lymphatic formations and first week of a disease repeat go to the small intestine and developing sensibilization, reaction sensibilization. And result developing sensibilization, developing inflammation. And cerebral swelling, it is inflammation. And what do inflammation? Pressure to vessels, to a wall of small intestine. Stop vascularization by developing necrotic mass, necrosis. Do you understand, doctors? Are you copied? Okay, copied. And what is developed? Dissemination will develop. From when Salmonella go to the bloodstream, from vessels go to the internal organs. It is dissemination. It means dissemination. Please. Why develop necrosis? Necrotic appear or it is doctors. Each human is individual, but result pressure of vessels stops vascularization. Developing necrosis usually on the second week of the disease. Please look, second week developing necrosis, and afterward the necrosis must be rejected. When developing rejection under necrosis, what is it? Ulcer. Ulcer. And when developing deeper ulcer, what is developing? Perforation. When developing necrosis, you're waiting complications, ulcer and bleeding. Where around bleeding, the vessel maybe developing intestinal bleeding. And doctors, surgical complication, perforation, intestinal bleeding, it is a surgical complication. These are surgical complications. No. Why? Parenchymatous organs, absent lymphatic tissue. And it is what go to first time. But how many doctors incubation period lasting 21 days? This time 21 days, Salmonella typhi was in the lymphatic formation and replicated and developing sensibilization. Copied? Have you questions? Okay, continue. Doctors, from pathogenesis you understand clinical picture, what is complication may be developing, and principal laboratory diagnostic and clinical classification. Typical classical clinical course. You will be discussed typical clinical course. And atypical clinical course, it is a modern clinical picture where developing abortive form. What means abortive form? Rapid onset of a disease, acute onset of a disease, but this disease lasts only 2-3 days and stop. Patient condition good, healthy. It is abortive form. Who have abortive form? Who vaccinated, who have antibodies. Ambulatory, in our name slowly, what is a subclinical cause, and rare forms where affected one organ, for example, affected lung, pneumo, typhoid, affected meninges, clinical picture, meningitis, meningotyphoid, affected bile duct and affected bile bladder, choleltyphoid, affected the kidney, nephrotyphoid, typhoid gastroenteritis, and choleltyphoid affected large intestine, colitis. And duration, acute, and with exacerbations and relapses. And severity, doctor, severity common, mild, moderate, severe, and when you talking about severe cause, when developing marked intoxication, temperature 40, patient has encephalopathy, and when developing complications, doctors, surgical complication and infection toxical shock connected with life of patient and characterize severe course of disease. Abortive patient vaccinated, patient has antibodies, and infected, developing acute onset of a disease, but disease lasting 2 to 3 days. High temperature 2 days, and next day, 3rd day or 4th day, temperature normal, patient's condition good. Because what do you do? With Salmonella typhi activated immune response, but immune response has what is information about this antigen, and now synthesis antibodies don't necessarily time to find what is infection agent on synthesis antibodies. Synthesis antibodies resistant. Ambulatory subclinical cause. Subclinical. Absent marked intoxication syndrome. Absent marked clinical picture. Our surgery is usually characterized ambulatory cause. Why? First days of the disease, patient used antibiotics. And maybe before developing disease, every time patient use antibiotics. You now viral infection, bacterial infection, our patients like antibiotics. And rare forms when reduced one organ. For example, patient has clinical picture pneumonia. You don't think about diagnosis typhoid fever because clinical picture pneumonia. Or for example, clinical picture colitis. You think about diagnosis shigellosis, but in the laboratory examination, you detect it from laboratory examination another infection agent, Salmonella typhi. Do you understand classification? And doctors, next part of our lecture is this clinical picture. Please look. And complicated, uncomplicated cause. You understand what is uncomplicated? Without complication. What is complication pathogenetic? What do you know pathogenetic complication? Perforation, bleeding, and shock. Infection toxical shock. And in our name, infection psychosis. And specific complication connected with pathogenesis, intestinal bleeding, perforation, infection toxical shock, infectious psychosis, and toxin affected heart muscle, myocarditis. And non-specific. Why develop non-specific complications? Without activated secondary bacterial flora. Pneumonia, thrombophlebitis, parotitis, cholecystitis, otitis. Pathogenetic, connected with pathogenesis. But a non-specific, it's result activated secondary bacterial flora. is what is fever. And please look, usually typical clinical temperature, it is trapezoid curve. What is? By step increased temperature. This day temperature 37.5, Friday will be 38, Saturday 38.5, and Sunday 39. And next after stay every day 39. And when developing recovery, step by step temperature decrease. Non-specific result activated secondary bacterial flora. Copy? Okay, continue. And doctor, it is classical temperature curve. Now it's modern temperature irregular, and it's severe because this day temperature 39, next day temperature 38, and repeat 39. And characterized severe cause and regular temperature curve. As temperature and malaria, yes? Decrease and repeat increase to malaria falciparum because absent epilepsy period, but temperature high and regular. Every day, yes, and 39. More maybe increase to 38 to 37, repeat 39 every day. And absent type period and absent epilepsy period. It is connected with a human response. And if you administer antibiotics in our clinical picture, and last century, when absent antibiotics, usually registered high% lethal cases. They could develop infection toxical shock. If infection toxical shock, what is BP? Drop BP, dysfunction of total organs and systems, and outcome. Or maybe, but surgical complications don't connect it with severity. And who have mild cause, who have severe cause, develop complication, surgical complication. But infection toxical shock connected with level intoxication. You understand? It is temperature curve. And together, when increased temperature, please look. Incubation period, I said you lasted how many times? 21 days usually. And minimum 7 days, maximum 25 days. And I said you, typhoid fever characterize cyclic course. What means cyclic? When one period, after one period, following next period. And initial period lasting 1 week. After second and third week, it is height period of the disease. First week, it is initial period. Second, third week, it is height period of the disease. And on the first week, you waiting, developing, recovery, convalescence period. And signs and initial incubation period were necessary now. For example, patient returned from India 10 days ago. Are you connected with disease with travel to India? Yes. And patient returned from Cameroon 6 months ago. Are you connected? No. Patient infected is well present now, well lived. And next, it is initial period when increased temperature. Together, when increased temperature, patient has clinical picture of intoxication, autism, malaise, weakness, a headache, and doctors disturbance of sleep, inversion of sleep. Why? It is specific characteristic. Severe cause when developing marked intoxication. You discussed acute hepatic encephalopathy. First sign of encephalopathy, what is? Inversion of sleep, yes? And when developing marked intoxication syndrome and for developing inversion of sleep, daytime sleepiness and insomnia or not deep sleep at night.
Start with the first day of the lead period.
Initial period, incubation period, absent clinical picture. What's mean incubation period? Infection agent replicated. It's common principle for all diseases. Necessary time to replication, to increase in infectious dose of the disease. And when developing clinical picture, it's initial period. Doctors, in this science, you don't detect a specific signs characterized with typhoid fever. But together, developing a disturbance of hemodynamics. Usually, when increased temperature, what do you waiting? Temperature 39. What do you do BP? What do you do pulse? It is, what is blood pressure drop, decrease or drop, and pulse very increase. And you know, when temperature increase and increase pulse rate. But to typhoid fever characterize relative bradycardia. What means relative bradycardia? Pulse normal, 76, 72, 78. And if you attended, you understand. Temperature 39, pulse must be 196, but pulse normal. Pulse don't correlate with high temperature. It's not absolute bradycardia because 72, 76, it's not. It's mean relative bradycardia. Boys, please stop talking. And relative bradycardia. First day temperature maybe correlate with pulse correlate with temperature, but on the third day you detected relative bradycardia. It's specific sign, and together you detected color of skin is pale, and detected Filipovich sign. What's mean? Disturbed carotene metabolism, and you detected illness of the palm and feet, only palms and feet, but another skin normal, another regions of skin normal, another regions of body. You detected only illness of the palms and feet. Its result disturbed carotene metabolism. The sign of Filipovich sign, and Botkin sign, flashing of the cheeks against the background of predominant pallor. And respiratory system function normal, but hemodynamics you detected lowering, decreased BP and deafness of tones, and you detected relative bradycardia And dicrotism of pulse. What means dicrotism? When you touch, when you detect it, what's rate of pulse, you detected two waves of pulse. Two waves of pulse, it's named dicrotism. The others of pulse and fit only, but another regions of the body normal color. It is carotene detox, carotene metabolism. Only pulse. Carotene metabolism, carotene detox. COVID continue. Objective science and first week of a disease, you detected increased size of tongue and size of tongue increased, and you detected white coated and edges and tip free of tongue from vacuum. Teeth imprints are visible. And why you detected prints of teeth? It's result teeth pressure to large tongue. Its name is loop. It's prints, teeth prints, and this loop. Margin of tongue and tip of tongue are free, but cover of tongue is white coated or maybe greenish white and maybe brown white. Patient has dryness of the oral cavity, and result dryness, what is it there? Microcarriage of mucous membrane of the tongue and bleeding mixture with cover and developing brown color. And it's named typhoid tongue. When tongue is large, swollen, when you detected teeth prints, and this tip is free and ages free. And doctors, please tell me why tongue is large? Why? Yes, it's very good. Yes. Now, information of lymphatic tissue and tongue rich lymphatic tissue and size of tongue increase. And together, we detected bloating and Padalkasine. What's mean Padalkasine? I said you, it's name of a scientist who described this sign. What is? Dullness of the percussion sound in the right iliac area. My question, why developing dullness of percussion sound? Why developed? Why developed? Very good. Inflammation lymphatic tissue open distal part of small intestine. And you percussion in the right under right iliac area, percussion sound is down. And together you increase liver and develop it stool retention. What means stool retention? Doctors, constipation. Maybe patient had 2-3 times peas porridge feces. Peas porridge. Peas like porridge. And after developing constipation. If constipation developing what is metabolism. And urination system, decreased urine output. And Padalkasine, you detected and increased liver size on the end of first week of disease. First days, what is appear? Relative bradycardia. and after increase size of the tongue, and therefore you detect the typhoid tongue, you detected pathococci. And doctors help to you epidemiological data. Patient hospitalized in your clinic with high temperature, and when you're talking, you detected anamnestic data. What is epidemiological data? Patient returned from endemic region. Or for example, patient drank contaminated water, unboiling water from ponds. Maybe drank technical water. It's correct. Copy? Okay, continue. And doctors, second week of a disease, it is disease characterized what is? Increased level toxins and characterized marked intoxication syndrome, and continue signs of first week of a disease initial period, but second week it is high period of a disease when manifested all signs of a disease and developing status typhosis. What means status typhosis? It is situation as encephalopathy, typhus, fog, and depression of the central nervous system, tenderness, disorientation, lethargy, apathy, delirium. Absent activity, patient sleeping at the night and without sleep at the sleeping during day and absent sleep at the night, and depression. And doctors, on the second week of a disease, appear pathogenetic basic sign of a disease. It is rash. Doctors, you must know time, place, and character this rash. On the 8 to 10 days of the after onset of a disease, it appears rash on the wall of abdomen and chest. It is single roseolus and characterized to this roseolus phenomenon or in addition. Doctors, to detect this rash, you must have good vision and attention. You detected 1, 2 single roseolus on the 8, 9, 10 days of a disease. And you round this roseolus, round. It is rows, rows, roseolus. On next day, you detected rounded roseolus change color. Color will be light brown as coffee with milk and tea with milk. But together you detected if you and you detected new rose roseolus turned around you. It's phenomenon for in addition against the background. All the roseolus you detected new roseolus. And after 2 days, this roseolus disappeared. And what is? It is a reaction of vessels. When you scratch this roseolus, that you detected Salmonella typhi. Please remember time 8 to 10 days, place, wall of abdomen and chest, and character single rose rash. And characterized phenomenon pouring in addition. And on the second week of a disease, increased spleen. You detected splenomegaly. Open. And doctors, please look. Necessary good vision to detect rose single roseolus on the chest and on the wall of abdomen. This rose roseolus. Have you questions? Okay, doctors. And third disease you will be discussed after a rest. Now, third typhoid fever disease characterized developing surgical complications. And doctors, you have a time to lunch, 30 minutes. And after 40 minutes, we'll be discuss complications. Okay? Doctors, online students, time for lunch, 40 minutes. And after return to this Zoom link. Okay?
Okay.
Are you listening, doctors?
Yes, yes.
Okay, after 40 minutes, return. Continue our lesson. And doctors, end of second week and third week of the disease appear complication. Patient has high temperature, intoxication syndrome, and appear complications. What is? Second week was psychosis, but third week surgical, and end of second week and first days of the third week appear surgical complications. Sorry. What is bleeding? Doctors, when appear bleeding, temperature drop. Why? Yesterday, patient had high temperature. Now, temperature normal or maybe subnormal. Why? Patient less of blood and absent in the peripheral zone. Blood, and together with blood, patient leave and toxin. And temperature decrease and drop. And compensatory when blood, circulatory blood decrease, and what does appear? Tachycardia, compensatory tachycardia. And patient's well-being improves for a short time, followed by deterioration due to blood loss. Doctors, and when patient, you examined least temperature and you detected decreased temperature, you must go to examine this patient. And what is a laboratory sign confirm bleeding? What is? Hemoglobin, yes, hemogram. Doctors, many students think bleeding, intestinal bleeding when appear melena, dark black feces, but it is later sign, appear later, because necessary time to pass this feces from small intestine, because developing bleeding of the small intestine to go to the large intestine, and this time function of the intestine stopped, dysfunction of intestine, because patient has metabolism and active motoric decrease, motoric of intestine decrease. And melena, it is later sign. First sign, it is tachycardia and decreased temperature. Do you understand? Mm-hmm. And next complication, perforation. Doctors, when developing perforation of whole organ, appear lancinated pain, but to typhoid fever is not characterized lancinated pain. Why? Because this perforative orifice covered of great amentum, and patient feel only moderate point pain in the lower part of abdomen. It is moderate pain, local point, non-intensive pain, and local tension of the muscles of the abdominal wall. And when increased peritonitis, appear marked distendence, but on the local tension, and disappearance of hepatic dullness. this perforation. And usually in surgical course, when developing perforation, appear lancinated pain. No, only local moderate point pain. And doctors, every time you doctor, on the end of second week, on the third week, appear complication. And I said to you, surgical complications don't correlate with severity of disease. Temperature 38, but appear complication, surgical complication. Patient's temperature 40, maybe developing surgical complication. And every time you question what patient feel, what's patient condition, and every time superficial examination of superficial palpation of the abdomen. Why? When you deeper palpate it, what does appear? Increase pressure of abdomen and developing perforation or bleeding. Only superficial palpation. And usually when exam is patients with students, my students don't touch patient, only talking and examine skin, but don't palpate it. Why? If 1 or 10 students palpate it, what is increased pressure of abdomen. And doctors, patients say to you, I feel moderate pain of the lower part of abdomen. First time you must administer hemogram. In the hemogram, what you detected? What is changed you detected? No, perforation. It's no. When developing bleeding, it could drop hemoglobin, but perforation, what is inflammation? Yes, it is from small intestine. Products go to the abdomen, appear peritonitis, developing inflammation. You detected increased level leukocytes, leukocytosis. And doctors, these patients must be examined, don't only infectious diseases doctor, and together must be examined surgery doctor. And you only say detected maybe catastrophe of abdomen, perforation, and surgical doctor must be examined, surgery must be examined, and administer hemogram necessary for you level leukocytes. Do you understand? 2 pathogenetic surgical complications, intestinal bleeding and perforation. Online students, do you understand me?
Yes, Professor.
Yes. Okay. And another specific complications, increase level toxin, result secondary bacteremia, and developing infection toxic shock and infectious psychosis. Infection toxic shock, what is? It is disturbance function of all organs and systems. But when developing infection psychosis, clinical picture of encephalopathy, patient agitated, patient apathy, emotional lability. And myocarditis, toxical effect of heart muscle, what is it here? Increase breathing rate, yes, and developing tachycardia and arrhythmia, arrhythmic pulse. And doctors, please, photo of perforative orifice. Typical ileal perforation associated with salmonella typhoid infection. Okay. Continue. And doctors, non-specific complicated of typhoid fever result activated secondary bacterial flora, pneumonia, otitis media, parotitis, pyelonephritis, osteomyelitis. Pneumonia is the most common complication of typhoid, paratyphoid fever disease and registered in the 3 to 4%. And 4th week of a disease, the period of extension, decrease of body temperature, decrease of intoxication, improvement of well-being, and patient has a standard vegetative syndrome and developing convalescent period within 2-3 weeks after normalization of body temperature. Temperature normalized, but patient feel weakness. It is prolonged convalescent period lasting 2 or 3 weeks.
It happened and bleeding during the acute typhoid. So how much longer will we to see this result in the schools or in the urine?
This bleeding registered.
Hours or
Doctors, I said you, time when it appear bleeding, end of second week, on the third week, when patient has ulcers, will be developing bleeding. Each patient, individual, one patient has bleeding on the end of second week, the next patient on the fourth week, third on the third week. How many time lasting ulcers, and this time you're rating bleeding and perforation. And when appear ulcer, end of second week of a disease and before convalescent. Convalescent is 5 and 6 weeks. And in the 5 and in the 6th week, you may be developing these complications. Before ulcers healing. Under healing ulcers. Copy it, continue, and doctor's clinical picture are typical forms. Abortive. What's mean abortive? Proctors to vaccinated, erased and rare. What's rare? Pneumotyphy, colityphy is a typical form of typhoid. Erased, what's mean erased? Subclinical. Yes. And outcomes. Our century of antibiotics, registered recovery in the 99%. Lethal case, 1.3%, 1%. And chronic bacterial carrier, 3 to 7, and average 5% chronic carrier. It is reservoir of Salmonella typhi with humans who have carrier, it is a reservoir of Salmonella typhi based on humans. Have any questions? And continue. And diagnosis. Doctors, have you questions about a clinical picture? And diagnosis, clinical and anamnestic data. What is anamnestic data? It is Anamnestic data, it is history of disease, when appear signs. And clinical, what do you objective examine it? And before hospitalization, patient say to you history of disease. Increased temperature was 37, next day 38, and step by step increase. It is clinical data. And clinical, what you detect it objective, what is high temperature, increased liver and spleen sizes, typhoid tan, appear Padalka sign, or appear specific rash, Rosello's rash. And epidemiological history, what's mean? Patient returned from endemic region and patient drank, for example, technical water, ponds water, river water, and patient had contact with persons with typhoid fever. Patient don't travel to endemic regions, but friend returned from endemic regions and now infected and sick. And this patient had contact and infected too. And physical examination, which you examination, and laboratory examination. Doctors, hemogram is done specific analysis, characterized only patient's condition. You detected leukopenia and neutropenia. And my question for you, what is disease of typhoid fever? What is who is the infection agent? It is bacteria. But you know, when developing bacterial process, what do leukocytes? Increase neutrophils, increase leukocytes, yes? And developing deviation to the left neutrophils. But to typhoid fever characterized leukopenia and neutropenia. And my question, why? You know, typhoid fever, it is bacterial disease. Why? It's connected with pathogenesis, you know. Yes, toxical effect bone marrow, very good. And affected bone marrow, you know, dissemination stage, and when developing a primary bacteremia, Salmonella typhi and the toxin disseminated to parenchymatous organs and reticulonuclear system organs. It is bone marrow too. And developing leukopenia and neutropenia. And result decreased neutrophils, relative increased lymphomonocytes. And doctors, blood culture, it is specific analysis, confirmed diagnosis. What is analysis confirmed etiology of disease? When you detected infection agent and detected response against this infection agent. And in the blood culture, you detected Salmonella typhi from the first week of the disease. From pathogenesis, you know, the first manifestation of the disease, what is? Fever, result bacteremia and endotoxinemia, primary bacteremia. And in the blood, you detected Salmonella typhi. And when you detected Salmonella typhi in the feces and in the urine, when you administer copper and urine culture. Second week, from liver, from kidneys, Salmonella typhi, a leaf of human body, from bile pass to small intestine. In the second week already. And from immunology course, you know, when you detected diagnostic titer of antibodies, diagnostic titer, on the second week of the disease, it's common principle. Antibody synthesis, but diagnostic level only will be only on the second week of a disease. And a serological test, viral reaction, indirect hemagglutination, and hemagglutination result positive 1/200, and will be positive on the second week of a disease. It is common principle. And additional laboratory test, it is immunological test, determination of a pathogen, antigen in the feces and duodenal content. But doctors, 100% confirmed diagnosis, blood culture. Why? Why urine culture and feces culture is not 100% confirmed diagnosis? Yes, but for example, I detected in the feces salmonella typhi. Why this analysis don't confirm diagnosis? When patients have clinical picture of typhoid fever, for example, fever and intoxication, and in the feces you detected salmonella typhi, yes, it's analysis confirmed diagnosis. But when patient condition normal and in our clinical sign, for example, patient has in clinical picture pneumonia, copper culture is don't confirm diagnosis. Why? Very good, carrier. And doctors, 100, excellent clinical picture. But in the culture, you detected salmonella typhi. It's diagnosed typhoid fever. If patient condition good, or maybe patient has clinical picture of pneumonia and clinical picture of appendicitis, and you detected in the feces salmonella typhi, it's maybe carrier because absent clinical signs of disease. And it's don't, and you understand, culture of feces, culture of urine is not confirmed or diagnosed on the 100%. Please, clinical case in our clinic. In our clinic, hospitalized younger man from Uzbekistan. It is a social element and had high temperature, and patient had intoxication syndrome and jaundice. You examinated to viral hepatitis and administer blood culture and administer X-ray examination. In the X-ray examination, detected bacterial pneumonia, and it is in the biochemical test we detected high level ILT and IST cytolytic syndrome and high level bilirubin. It is characterized laboratory test of viral hepatitis A acute phase. And together we detected antibody hepatitis A virus immunoglobulin M. And our diagnosis was acute viral hepatitis A, extended form, moderate cause, and pneumonia, bacterial pneumonia. But after we take information about blood culture, detected salmonella typhi. And it's mixed diagnosis and was acute viral hepatitis A with typhoid fever, detected salmonella typhi. And after 1 week, prevalent clinical picture, typhoid fever, and after developed a surgical complication, bleeding. And patient infected two infection agent virus, hepatitis A, and bacteria, typhoid fever, salmonella typhi. But before manifested clinical picture, typhoid fever, in the blood culture, we detected salmonella typhi in the blood. Right? An immunological test, it is only help to you, it is additional laboratory test. And our century, blood culture, 100% confirmed there. Any questions? Okay, differential diagnostic search. Differential diagnostic with paratyphoid A and B. What is different? The paratyphoid A and B characterized shorter duration of illness, less pronounced intoxication, and the onset of disease is more acute. The maximum temperature from the first days of the disease, wrong type of temperature curve, and specific characteristic rash. Rash appears early on the 5th day of the disease, and another characteristic, polyprofuse, polymorphic. Now, to typhoid fever characterized single and only rosellas, and with localization on the limbs. But now localization, rosellas on the wall of the abdomen. and chest. Exacerbations are less common, and paratyphoid A is characterized by onset with signs of acute respiratory infections, and paratyphoid B is characterized by a beginning with gastrointestinal manifestations. And clinical picture: paratyphoid A were prevalent respiratory disorders, developing pneumonia, and when developing clinical picture of gastrointestinal tract affected, what is gastrointestinal infection diseases, intestinal infection disease, you must think about diagnosis paratyphoid B. And tactics of examination and treatment are similar for typhoid fever. Copied? Have you questions? Copied? Okay, doctors, and paratyphoid A and paratyphoid B, what is common characteristic of typhoid fever? Intoxication syndrome and epidemiological analysis, what is characterized to endemic regions, South regions, and characterized developing rash, increased liver and spleen sizes, but another characteristic rash: time, place, and character, polymorphic, and appear on the 5th day of disease, and characterized, usually prevalent, affected only or lungs or gastrointestinal tract. And differential diagnostic search with diseases with high temperature. Influenza characterized seasonality. When is season of influenza? When? Autumn, winter, and spring, and early spring, late autumn and early spring. And characterized high temperature, and influenza patients don't answer to antibiotics, and characterized, it is common, but what is another? Disease lasting 5 days, high temperature. After 5 days, temperature normalized. But two influenza characterized developing dry catarrhal syndrome. Two typhoid fever don't characterize dry catarrhal syndrome. Next, typhus, another name, Brill-Zinsser disease. Epidemiological analysis helped you, and from epidemiological analysis, you must detect information about pediculosis. It is characterized to typhus, who infected Brill-Zinsser disease. In the analysis, patient had typhus, and in the analysis, when infected typhus, patient had pediculosis. Intoxication with excitation of the central nervous system, hyperemia of the skin, of the face, with the hood, and characterized another character of rash. Rash appear on the 5th day of the disease, and roseolus petechiae rash, and developing productive psychosis, focal neurological signs, and the affected nervous system, and developing clinical signs of Escherichia paradox. What's mean Escherichia paradox? It's term Escherichia paradox. Absent diuresis, if ischuria, but function kidney normal. What is laboratory test characterize function of a kidney? Very good. You exam creatinine normal, and you detected urine bladder full and up of symphysis, but absent urination. Its result disturbed information from vegetative ganglions, and don't take information from vegetative ganglions. From vegetative ganglions information, stop it, don't go to the brain. And patient don't feel full empty, full urine bladder, think it's empty and absent urination. And it is but to typhoid fever, you now don't characterize disturbed information from vegetative nervous ganglia. It is affected peripheral nervous system and developing productive psychosis. And malaria, you know, a common epidemiological region. Malaria endemic region and typhoid fever common endemic region, which is tropical, subtropical Africa. But to malaria characterized paroxysm, chill, fever, and sweating. But you know, to typhoid fever don't characterize paroxysm. Appear only high temperature, absent sweat, absent epilepsy period. And to malaria, usually first prevalent increased spleen and later increased liver. But to typhoid fever, first time increased liver and later on the second week increased spleen size. And to malaria characterize hemolytic anemia. And if developing marked hemolytic anemia, you detected jaundice of the skin. But to malaria characterized hemolytic anemia, hemolysis of erythrocytes, and malaria characterized illness of the sclera and skin. But to typhoid fever, illness is not characterized, only developing what is sign of Filipovich, illness of the palm and feet. Result disturbs keratin metabolism. And you know what is common: influenza, typhus, malaria. Don't answer to antipyretic drugs. Short-term temperature decrease, but repeat increase. And to typhoid fever characterized before administer antibiotics, temperature will be stable. Do you understand? Different diagnostic stage. And other diseases. We will be discussing yersiniosis characterized prolonged fever, and typhoid fever characterized prolonged fever. And to yersiniosis characterized increased liver and spleen sizes, but to yersiniosis don't characterize endemicity. Illicit in the worldwide, where source of infection mice will be discussed this semester. And sepsis. Characterized high temperature, is regular temperature, and increased liver and spleen sizes, septic it is. Bacteremia, as typhoid fever, generalized disease, and appear rash. But what is rash of septic rash? Polymorphic and total all body. And to sepsis, usually you know information. Patient had focus of urinary process. For example, bronchiolitis, or for example, pyelonephritis, where there was focus of infection agent. And doctors, on Friday we will be discussing salmonellosis. Salmonellosis, it is localized disease when affected only gastrointestinal tract, but maybe developing rare cases, 1% registered generalization process. And to salmonellosis characterized generalized form, typhoid-like clinical picture as typhoid fever, but this clinical picture don't appear over the first days of the disease. First time patient had clinical picture, intestinal infection, localized from what is diarrhea, and developing intoxication syndrome or dehydration result developing nausea, vomiting, and diarrhea. And after diarrhea stop and appear clinical signs of generalization process. What is increase temperature, increase liver and spleen sizes, and appear rash as typhoid-like rash. What is rash? Rosellas. But for typhoid fever, don't characterize developing clinical picture of intestinal infection disease. Absent watery diarrhea, patient has only what is as porridge-like, fish porridge like feces, and after developing what is meteorism, and now came this picture. But our students mistake read task of generalized form ceremonialosis and diagnose typhoid fever because forgot information. 1 week ago, patient had clinical picture intestinal infection disease, but now patient has clinical picture typhoid fever and diagnosis will be typhoid fever because don't correct, distract. Any questions about differential diagnostic search? Okay. And doctors, let's rest 10 minutes to coffee break, 10 minutes. And after will be discussed therapy. Please, online doctors, please. After 3 minutes, stop walking Zoom. After 10 minutes, return.
Okay.
Are you listening?
Yes, okay.
Okay. Picture. You said me why? What preventive measures necessary administered to prevent surgical complications? You know, if patient walking has physical examination, increase abdominal pressure, and our way to prevent it developing complications, surgical complications, necessary administer strict bed regimen. Stop physical examination, stop walking, and administer anti-ulcer diet. And food must be is don't very hot, is don't cool or normal temperature, acceptable temperature of food, and without irrigated products. For example, acids, only lemon on spices. No, only porridge with milk and porridge and milk products and boiling eggs. These products recommended. And don't administer coffee because coffee irrigated with mucous membrane. And this is to only administer. Don't administer juice because in juice activated patotic of intestine. And doctors. But how many times are you want to administer strict bed regimen? From pathogenesis, you know. How many weeks, a lasting period when maybe developing complications? Weeks? Sorry. How many time lasting? Duration. Yes. Time when you wait in complication. Okay. How many time lasting time of complication? End of second week, appear complication. And how many times prolonged? No, 2 weeks. End of second week, third week, fourth week. When appear convalescent healing of ulcers? 5-6 weeks. And during this period, our patient must be hospitalized in the clinic. Patient condition good. Patient said, please me discharge from hospital. But you must be every time examining patient. And because maybe developing complication. And what do? You must administer strict bed regimen. And Patient conditions must satisfactory or moderate, but patient must be hospitalized. All patients hospitalized. It is clinical data and epidemiological data, because patient source of infection and patient must be hospitalized together. You don't know, is surgical complication don't correlate with severity. Mild cause and severe cause % developing complication common, and necessary hospitalization according to clinical and epidemiological indications. And strict bed regimen. Doctors, please remember, in the exam, it's question about typhoid fever therapy. First time you must answer regimen. All high period of disease and plus all high fever or time and plus 7 days of normal temperature. Strict bed regimen, rest until the 7th day of normal temperature. Temperature lasting 5 days. 5 days. You administer antibiotics and temperature normalized. But plus fever period plus 7 days of normal temperature. And strict bed regimen. And patient in the bed and urination and defecation in the bed. And from the 7th day to 10th day, normal temperature, patient is allowed to sit on the bed and add eating products and urination duration in the sitting. But from the 11th day, patient may walk, but don't walk in the department in the street. No, go to WC and return to room, to bed. Why? Because when increase abdominal pressure, developing ulcer, prevention ulcer. It is what is measures prevented ulcer process. Perforation, ulcer present. What is measures prevented surgical complications, bleeding and perforation. It is diet, anti-ulcer diet, and administered bed regimen. And it is measures and therapy. Salmonella typhi bacteria. You must administer drugs against gram-negative bacteria. This time effective drug, ciprofloxacin. But doctors, you must know we live in the resistant century and maybe developing resistance. And what is scheme of the therapy? According to the scheme of a long continuous course, regardless of severity of the cause and form of typhoid fever, up to 10 days of normal temperature. And patient had high temperature during 5 days. 5 days, patient used antibiotics, temperature normalization, and plus 10 days, patient used antibiotics. Usually when you administer antibiotics, on the 3rd day, patient must be answered to your therapy. On the 3rd day, temperature must be decreased and after normalized. And doctors, this drug now effective, ciprofloxacin. But doctors, please remember how many days? Fever periods plus 10 days of normal temperature. Or after stop temperature, after normalization temperature plus 10 days. And administer ciprofloxacin, administer aminoglycosides, it is gentamicin and cephalosporins of 3rd or 4th generation. A history of the therapy. 1948 in the Malaysia was registered focus of disease, administered chloramphenicol. It's in our name, levomethacin. And chloramphenicol was very effective. But after administering chloramphenicol, developed resistant cases. And it is a specific characteristic bacteria. Bacteria must be kept in population and develop resistance. And doctors, a 1980 World Health Organization recommended its first line of drug administer chloramphenicol, administer bisoprolol, and administer gentamicin. But after 1980 in the Asia and before 1980 against chloramphenicol registered resistance. 1990 good drug was ciprofloxacin, ftorkinolines. And now this drug administered. But in the Asia against this antibiotic developing resistance now. And now in the Malaysia return administer chloramphenicol, levomethacin succinate, effective now. And ftorkinolines is not effective now. But in the Europe now recommended ftorkinolines. But now you don't administer one antibiotic group. Recommended administer 2 or maybe 3 groups antibiotics because developing resistance. And what is now in recommendation is drugs, but you don't know what will be after 1 year, after 3 years. Pharmaceutical company working every time and synthesizing new antibiotics. And doctors against ciprofloxacin registered resistance, against aminoglycosides registered resistance, but against cephalosporins, it's named cefotriaxone, rare registered resistance. And it's drugs reserve, antibiotic reserve, it is cephalosporins, cefotriaxone. And doctors, it is, you have 3 elephant of therapy. First elephant is etitropic drugs. Second elephant, what is? Pathogenetic. And third, symptomatic. It is 3 elephant. And at etitropic you administer, and together you must administer pathogenetic. Our patient has intoxication syndrome, and you must administer disintoxication therapy. What means? It is colloid and crystalloid solution. Recommended administer per orally if patient may drink water, but patient condition worse, patient apathy, and this patient don't may drink little of water, and what is not effective, necessary administered colloid solution too. Colloids take toxin, you administer intravenous, and combination intravenous plus per orally. And doctors together, you administer symptomatic therapy. When developing surgical complication, intestinal bleeding, you must be administered hemostatic therapy, sodium ethamzolate, 10% solution calcium chloride, 5% aminocapronic acid, and 1% bicasol solution. When developing perforation, patient hospitalized in the surgery department, necessary administer organ surgery. Only operative measures.
But usually always infected with the typhoid virus.
No virus, bacteria.
Bacteria. Always in the future, this bacteria will come back again.
No, don't come back. Rare when immunocompromised patient. I said you. One time, developing lifelong post-infection immunity. Only immunocompromised patient repeat infected. Doctors, have you questions about therapy? Do you understand? And what is problem of therapy? Resistance. And to administer one course antibiotic therapy, but this course is not effective. And when you understand, if during 3 days temperature don't decrease intoxication syndrome, necessary change, administer another course of antibiotic therapy, and maybe plus administer third and second antibiotic. Usually recommended administer 2 antibiotics together now. Don't wait in what will be effect. And when you understand developing complications, it recommended administer and developing complication administer metrogel, antibiotic metrogel. And doctor, now World Health Organization recommended fluoroquinolone drugs, but what will be next time, we don't know. Okay, and rules discharge from hospitals. After clinical recovery, patient discharged from hospital, but don't live on the 21st day over normal temperature in patients who received antibiotic therapy. It is prevention surgical complications. You must be examinated patient condition good, but early 21st day of normal temperature, patient don't discharge from hospital. And not earlier than 14th day of apyrexia who didn't receive atypical therapy. And rehabilitation control is carried out before discharge from the hospital. Before detected 3 negative results, urine culture, feces culture, and 1 negative culture of the bile, patient don't hospitalize from hospital. And stop therapy, and therapy lasting minimum 2 weeks, and after 2 days rest, and after 2 days, for example, therapy stopped Sunday, and when you administer laboratory examination, feces and urine, Sunday, it is final day of antibiotics therapy. Wednesday, 2 days, after 2 days. And on Wednesday, you administer laboratory examination, feces and urine with interval 2 days. On Wednesday, you take feces and urine to bacteriological examination. And 2 days rest. And Saturday, second time, you take feces and urine. And after Saturday, when you will take third analysis, first analysis Wednesday, second analysis Saturday, and interval 2 days. Tuesday. A material for bacteriological research is taken than 2 days after the withdrawal of antibiotic and interval with 2 days. And when you take third result of coprin in urine culture, you take bile to examination, because who is a carrier, bile carrier, where good medium to semi-type bile. And usually the carrier of feces carrier, rare registered urine carrier, but epidemiological hazard urine carrier, because those of Salmonella typhi large, and urination urine dose large than feces dose. And times of urination, defecation will be 1 time of day, but 2 times. But urination, how many? 5, 6 times every day. And epidemiological hazard, urine carrier than feces carrier. And rules of discharge from hospital: 3 negative results, feces, 3 negative results urine and 1 negative result bile. Bacteriological examination feces, urine and bile. And continue. Clinical examination of convalescent. Convalescent patients when you detected all negative results, examined in the ambulatory, because don't go to the job. 1 month ambulatory examined, because continue period reconvalescence, continue asthenia, and thermometry once a week in the first 2 months, and once every 2 weeks during the next month. Every week during 2 months, necessary administer exam temperature. And bacteriological examination, copra and urine culture, 1 month, 1 time each 3 months. At the 4 month, take bile to detect it in the bile, Salmonella typhoid. And together, when you administer third examination, copra and urine culture, you administer serological test reaction in direct human vaccination with the antigen. Why the? Where the antigen? It is superficial antigen. Superficial antigen. If the research results are negative, those who have had typhoid fever are removed from dispensary observation. It is rules to humans who don't work in food industry. And doctor, my questions. At the hospital, when you examined patient, in one analysis, you detected urine culture or feces culture positive. What do you do? No, check blood culture. Why? Now, if stop clinical picture and in the blood absent bacteria, because absent endotoxinemia. Why developing clinical picture? And intoxication syndrome connected with endotoxinemia. And this time bacteria absent in the blood, but present in the feces, in the urine. What is developing? Carrier. Before 3 months, it is acute carrier. After 3 months, it is chronic carrier. And why exam 3 months in the ambulance? Acute carrier maybe. It's but after 3 months, usually Salmonella typhoid disappear. Only 5% of patients developing chronic carrier. And recommended administer at the hospital second course of antibiotic therapy. Patient don't answer to this course antibiotic therapy is don't eliminate it bacteria, but necessarily recommended second course to eliminate it Salmonella typhoid. When second course is not effective, patient don't live during lifelong in your hospital. Patient discharged and examined in ambulatory. And after 3 months ambulatory examination, will be prognosis healthy, acute carrier stopped, and patient healthy. But if continue detected Salmonella typhoid feces, it is chronic carrier. But it is patient epidemiological hazard to members of the family. But if this patient work in food industry, this patient source of infection to all people. And another rules examination. Who working in the food industry is named decreased groups. After discharge from the hospital, they are not allowed to work for 1 month. They don't recommend stop working during 1 month. And 5-fold copra urine culture during 1 month examined. Each week examined. You must take feces and urine to examination. When 1-fold copra urine culture and reaction in direct urination for the next 2 months. And this patient, if working in food industry, if working every time examined in the ambulatory. In the next 2 years, corporate urine culture, one time examined in 3 months. Further, through the anti-labor activity, corporate urine culture 2 times a year. And you know, dispenser examination who work in food industry every year. And every year, 2 times, usually recommended 1 times, but who infected typhoid fever 2 times every year. It is after 6 months. It is rules of examination. Do you understand? Online doctors, do you understand? Rules examination.
Yes.
Yes,
And
Professor.
rules hospital. Okay. And epidemiological hazard, chronic carrier, and who work in food industry. Okay. Continue. And prevention, doctors. Prevention, it is necessary prevented typhoid fever to service epidemiological service and clinical. Clinical, what do you do? Detected ill patients and hospitalized, isolated, hospitalized, and treated. But epidemiological service must be disinfected flat home where detected ill person, and first time epidemiological service must be examined central water and examination what working canalization system. Early detection of patients and bacteria carriers, early hospitalization of patients. It is function of the doctor. And clinical and laboratory examination, contact persons, it is a rule, it is a work controlled epidemiological service. Information about how many contact persons examined and how many persons infected, contact persons, it's information necessary sent to epidemiological service, because epidemiological service controlled. And epidemiological examination and disinfection of in the focus of infection, it is function of the epidemiological service. And strict adherence of the rules for discharging convalescents, dispensary observation of patients with typhoid fever in the office of infectious patients in the polyclinic ambulatory. It is work of doctors, but examinative, controlled epidemiological service. And registration and observation of typhoid carriers in the centers of sanitary and epidemiological surveillance. And it is a function of epidemiological service. And doctors control central water. It is total principle to prevention distribution typhoid fever. But in endemic regions, when mortality more 25 to 100,000 people, recommended vaccination. Present 2 vaccines, Tifivac and Vianvac. Tifivac administered to adults from age 15 to 55 years. It is alcohol vaccine, administered subcutaneous 1.5 milliliter. First time, doctors, please turn on your camera, telephone. And after 1 month, second dose, administer 1 milliliter dose vaccine. And this vaccine will be effective during 2 years. After 2 years, repeat administer revaccination. But who is vaccinated? who live in endemic regions and may be infected, have risk infected, and humans who live on endemic regions but now go to the endemic regions from air travel and connected with job blocking in these endemic countries. And recommended TIFI-VAC. It is a vaccine to adults and to children from 3 years. Recommended vaccination VAC, where present the antigen of live bacteria, and administer 1 dose, 1 milliliter. And after this vaccination, antibodies immunity persisted 1 month, and 3 years. And don't administer second dose. Only 1 dose, 1 milliliter recommended administer. TIFI-VAC 2 dose administered, VAC 1 dose, and antibodies usually persistent 2-3 years, and revaccination recommended on the 3rd year, after 3 years, on the 3rd year. It is principal vaccination, but in endemic regions, endemic countries. It's full information about typhoid fever. I have questions? If absent questions, doctors, you must discuss 2 tasks. Task of typhoid fever in modern course now, where developing atypical cause, when developing resistance. Okay. Please, attention. You must together walking. Please. Patient. Hospital. Case absent. I read for you, okay? Listen me. Doctor. Patient, 33-year, hospitalized in our clinic with diagnosed intestinal infection. With complaints during 1 month, patient has had high temperature up to 40 degrees by centigrade and porridge feces 3-4 times every day. Weakness and less of appetite, decrease of appetite. And information about patient's life. Patient live in hostel. On the moment hospitalization, who work with this patient, hospitalized in the infection diseases clinic with diagnosed typhoid fever. Patient had contact, but it is colleagues who work together. And epidemiological data, information. Patient drank technical water where worked. And husband of patient hospitalized in the clinic were diagnosed typhoid fever. Colleagues and husband work together. And it is a migrant work and live at hostel, and work in the fabric where fabric is don't certificate fabric, and patient drank water from WC, technical water. And on the moment examination, patient had 33rd day of the disease. During 33 days, patient had high temperature and intoxication syndrome, severe condition, and consciousness norm, temperature 39.9 degrees by centigrade. Normal. And color of skin is pale, and in the region of epigastrium and light costal rib, 2 roseolas. Detected 2 roseolas. Tongue is swollen and prints of teeth and covered, yellow cover and dry. Tongue large, teeth of prints, yellow cover and dry. BP 95/65 and pulse rate 114. This pulse, tachycardia, absent relative bradycardia, and respiratory rate 18. Respiratory and pulse correlate with temperature 39.9, and meteorism and respiration rate 18 normal. No, you know what is respiration rate? 16, 18, normal. And meteorism of abdomen. And in the right iliac area, moderate pain, hepatomegaly, and one time was defecation and marked green color feces without pathologic admixture. Сейчас лекцию закончу, перезвоню, ладно? Without pathologic admixture. And if patient has prolonged disease and epidemiological anamnesis, contact with typhoid fever patient, and patient drank technical water, and prolonged fever, prolonged disease, prolonged fever, marked intoxication syndrome, single rosellas, and what is diagnosis? You first think, primary diagnosis was typhoid fever disease, typhoid fever disease, typhoid fever, or paratyphoid A and B2, yes, and paratyphoid disease before laboratory examination, and administer antibiotics. What's recommended World Health Organization? Ciprofloxacin, Turkey Alliance, and administer ciprofloxacin intravenous. Patient had severe course and prolonged course of disease, administer metrogel, and administer cefotaxime. 3 antibiotics together. Cefotaxime, it is what is drug of cephalosporins. Cephalosporins, 3 groups antibiotics administered. In the hemogram, leukocytes 8.5 thousand, band neutrophil 9%, segment neutrophil 74%, lymphocytes 14%, monocytes 3%, ESR 18 millimeter ABR. Moderate increase ESR. And on the 4th day of hospitalization, in the hemoculture detected Salmonella typhi group D. Its analysis confirmed diagnosis typhoid fever, severe course. But against the background, our antibiotic therapy, temperature decrease. But on the 10th day of the antibiotic therapy, temperature repeat increased to 38.5. Repeat increase. And our patient don't answer to antibiotic therapy. First time answer, but after repeat, what is developing? Relapse. And appear new rosellas. And you understand why developing rosellas in the blood bacteria. And you know it's reaction of vessels at this rosella. And when you touch with rosellas, we detected from this rosellas Salmonella type bacterial infection agent. And change therapy. Administer chloramphenicol, levomethacin. It's later. First, administer chloramphenicol, levomethacin. change character or change therapy, and administer meropenem. Against the background with therapy, developing positive dynamic, but registered periodically increased temperature up to subfebrile, and on the 19th day of therapy and 31st day of hospitalization, repeat appear neurozealous. Temperature don't high, subfebrile, but repeat increase appear rozealous. And you understand if rozealous bacteria in the vessels, bacteremia, and leukocytes. This therapy developing resistance and prolonged disease, and don't develop infectious toxicity. 30 days, 1 month, patient had high temperature, but don't develop infection toxical shock. And characterize what is in our situation. You usually waiting relative bradycardia, but our patient had tachycardia. Why? It's maybe together activated secondary bacterial flora, and the patient had high temperature. You don't know. It's I said you each patient individual, but clinical picture present, but together you must be detected infection agent. Continue. And doctors administer third course of antibiotic therapy, and on the 31st day of hospitalization, appear neurozealous and leukocytes 4.9 and lymphocytes 19, bent neutrophil 1%, sediment neutrophil 78, monocytes 2, DSR 36, 2 times increase DSR. And administer levofloxacin. It is fluoroquinolone drugs, levofloxacin. And administer doxycycline. What do doxycycline effective against intracellular parasites? Administer doxycycline. On the second day of the third course of antibiotic therapy, registered positive dynamic, rozealous disappear, and patient had every day normal temperature. And patient used 3 course of antibiotic therapy. Only on the third course of antibiotic therapy, patient condition normalized. Doctors, it is this clinical case demonstrated polyresistance to antibiotics. Salmonella typhi polyresistant. And next case, young man, 24 years, hospitalized in our clinic with diagnosis, primary diagnosis, acute respiratory viral infection, acute bronchitis on the 5th day of the disease. And information about disease, acute onset of the disease with temperature 37.6. On the next day, temperature increased to 38 and increased weakness. Patient used paracetamol and bromhexine because patient think about diagnosis acute respiratory viral infection. On the second day of the disease, temperature 39. Doctors, step by step, 37.6, 38, 39. And appear single dry cough and pain in the low parts of the chest. And patient think about pneumonia and come to doctor and examine it in the ambulatory and diagnose acute respiratory viral infection. On the 4th day of the disease, temperature was 40. Step by step, yes, increased temperature. And patient complains, headache, nausea, 2 times vomiting, and patient hospitalized in our clinic with diagnosis acute respiratory viral infection, bronchopneumonia question. because auscultative, doctor don't detect it, cracks. And on the woman hospitalization, patient condition moderate severity and temperature 38.5 and skin normal color without rash, hyperemia of all over throat, and increased tonsils to tube stage, and palpating submandibular lymph nodes, and respiratory rate 18, and dry cough, and pulse 98, BP 110/80, tongue is dry, coated, abdomen is soft without pain, liver and spleen don't increase. Urination don't disturb, and one time was feces porridge character. Porridge. And from epidemiological analysis, patient walk in airport Domodedovo and usually work with documents, migraines. And when I talk with patient, and patient said absent time to lunch, and patient maybe don't every time wash hand, and in the West job we're working on the desk where present migrants with documents and add products, add food. And I think patient add nuts from Tajikistan, but doctors nuts absent medium to reproduce bacteria, to replication bacteria. Necessary what is protein, milk, meat, and bile, yes, is absent and the nuts. And I think patient gets infected without contaminated surface of desk. And when this desk patient put products and contaminated products and infected. But in the analysis, leukocytes 6, parent neutrophil 16%, neutrophiliosis, deviation to the left, and segment neutrophil 41, thrombocytopenia 102, ESA 10 mm/hour. In the biochemical test, creatinine 129, moderate increase, normal 100, IST increased to 54, normal 30, 40, moderate increase, don't critical. You know, when developing cytolysis, figure ILT and IST 1000 level, 1000 and more. And ultrasound examination detected splenomegaly, but X-ray examination of the lungs, absent pathology. And bronchopneumonia diagnosis is don't confirmed. And administered to patient ceftriaxone. Ceftriaxone, what is drug? Cephalosporins and clarithromycin together, 2 drugs administered, 2 antibiotics, 2 groups administered. On the 8th day of the disease, on 5th day of hospitalization, diagnosis is don't clear. And patient had during 8 days fever, marked intoxication syndrome. Patient had catarrhal signs, dry cough, and laboratory and instrumental examination. And patient administer antibiotic because primary diagnosis was fever unknown etiology. Why? During 8 days, patient has high temperature. And a patient examined to malaria, legionellosis, chlamydiosis, myoplasmosis. Patient examined to all diseases with registered fever. Mycoplasmosis, chlamydiosis, legionellosis, malaria, toxoplasmosis, brucellosis, borreliosis, encephalitis, anaplasmosis, herpes viral infection, Epstein virus, cytomegalovirus, infection in intestinal diseases, salmonellosis, shigellosis, yersiniosis, cholera, HIV infection, acute viral hepatitis, acute respiratory virus infection, influenza virus, parainfluenza virus, adenovirus, parvovirus, respiratory distress syncytial virus, and all results negative. On computer tomography of the chest, don't detect abnormalities. On the 9th day of the disease and 5th day of hospitalization, temperature 39.3. Patient used antibiotic, temperature, normalization. Yes, repeat increased temperature and detected hepatomegaly in the blood, leukopenia, leukocytes 2.4, drop, leukocyte, lymphopenia, and thrombocytopenia 97. On the 12th day of the disease and 8th day of hospitalization, detected relative bradycardia and detected on the 12th day of the disease. Detected single roseus. I said you, time of appear roseus, 8 to 10 days. But this case, roseus appear later on the 12th day of the disease. And single roseus on the wall of abdomen, and appear phenomenon proving an addition against the background. All the roseus appear new roseus. And detected Salmonella typhi group D in the hemoculture, in the culture of the blood detected. And diagnosis, what is? Typhoid fever. What is cause? Temperature 40. Severe cause of disease, severe cause. And doctors developed myocarditis, complication myocarditis. And after therapy, patient discharged from our hospital. Younger man, 24 years, but toxical effect toxin, and the patient had complication myocarditis. These two cases are characterized as modern cause of typhoid fever, were developing resistance and developing rare complication myocarditis. Please remember these cases. In the exam and final lesson, you must say typical clinical picture, but you must now, patient may answer to you therapy and necessary administer and find better antibiotic. Have you questions? Tell me please, what is film is single for you, is simple for you? Typhoid fever, malaria, or viral hepatitis? Malaria? Typhoid fever, pathogenesis is simple. Yeah. Respiratory absent, X-ray examination and computer tomography don't detect. On the irrigation of the, my patient, doctors, my patient had dry control syndrome, increased lymphatic tissue of the lymphofaryngeal vein and irrigated when patient breathed. Oh, what is? No, detected Salmonella typhi group D. Differential diagnostic search, yes, for typhoid A. But don't detect it. Detected Salmonella typhi group D. Doctors, please arrest. You have arrest to lunch. You have 15 minutes to coffee break. Online students, are you listening to me? Online doctors.
Yes. Yes, doctors. Yes.
Please go to your teachers to link Zoom of your teachers, okay?
Okay.
Okay, goodbye. Please, doctor, question.